All right, let's lock this in. This is the final synthesis for the Pituitary Command Center. If you want to own this gland, you've got to master its core logic gates. Let's get started. Okay, rule number 1, prolactin is high. You absolutely have to look at it next to the size of the mass. A massive rise, we're talking over 200? That's a true secreting tumor, no doubt. But what if it's just a little bump, under 100? That's the Stalk effect, just plain old compression. Next up, if the body's growing way too fast, look, trying to chase the growth hormone itself is a rookie mistake. It's all over the place. You measure its shadow, IGF-1. That's your steady, reliable target. Logic gate number 3. The urine is dilute, the patient can't stop drinking water. The key move here is checking the desmopressin response. It's a clean split. Do the kidneys respond? The problem's central. Do they ignore it? The problem's in the kidneys, nephrogenic. Done. And here it is, the master key, the ultimate diagnostic shortcut that unlocks the toughest questions. If you see diabetes insipidus plus a total failure of the other pituitary hormones, what we call pan-hypopituitarism, the problem isn't the gland itself, it's the stalk. You are looking at an infiltrative disease. Look, it all comes down to this. Mastering this decision loop is the entire game. You master the loop, you get the points. It's that simple. Now, before we tie this all together, a quick protocol update. Okay, just a quick but important heads up. This material is for educational and exam prep purposes only. It is not medical advice. For any clinical decisions, you always consult the official guidelines and a specialist. All right, with that out of the way, let's put it all together. We've explored every single level of the Pituitary Command Center. Now, we're adding the final, and I mean the most critical, branch to our entire decision tree. So get this clinical picture in your head. A patient has confirmed diabetes insipidus. Think sky-high sodium, super dilute urine. But on top of that, their labs show their adrenal glands and their thyroid have failed, and it's a secondary failure. This isn't just one little hormonal glitch. The whole system is collapsing. So where's the fire? So how do we piece this puzzle together? It's actually brilliant when you break it down. Step 1, just having diabetes insipidus tells you the problem's got to be high up, in the hypothalamus or the pituitary stalk where ADH is made and transported. A simple tumor down on the gland itself almost never causes DI. Step 2, but wait, multiple other hormone failures, pan-hypopituitarism. That tells you the anterior pituitary gland is failing. So how on earth can you have both at the same time? Aha, that's step 3, the big reveal. A lesion in the pituitary stalk does both things at once. It cuts off the ADH signal coming down from the brain, and it chokes off the blood supply to the gland below. That's the stalk invasion shunt. And this is the classic signature of an infiltrative disease. For your exams, your brain should immediately jump to things that can literally invade that tiny, critical stalk. What are the big ones? Sarcoidosis and Langerhans cell histiocytosis are the classics. So burn this into your mind. DI plus pan-hypopituitarism equals infiltrative stalk disease. Period. Okay, you've got the master key, but now we have to talk about the classic board trap they'll use to try and trick you. Let's talk about the empty sella. So you see an MRI report and it says empty sella, and you look at the scan and it's like, whoa, where did the pituitary go? It looks totally squashed or maybe just gone. But you know what? 9 times out of 10, this is just a weird anatomical thing, a totally harmless and incidental finding. And this brings us to one of the most important rules in all of medicine, and definitely for your exams. You treat the patient, not the scan. If that patient's hormone labs are completely, totally normal, the right answer is to do nothing. Don't you dare fall into the trap of intervening just because of an image. All right, enough theory. Let's make this muscle memory. Time for the pituitary compass drill, rapid fire, no hesitation. You ready? Let's go. DI plus pan-hypopituitarism, your answer is infiltrative stalk disease. Think sarcoid. Prolactin, way up, over 200. With a mass, that's a secretory adenoma. Easy. Prolactin, just a little high, under 100, but with a big mass? That's the stalk effect. It's just compression. Empty sella on the scan, but the labs are totally normal? What do? Nothing. You observe. It's an incidental finding. And the big one, the safety check. Replacement order when everything's crashed? It's cortisol before thyroid. Say it with me. Cortisol before thyroid. Always. That one saves lives. You see the pattern here? It all comes down to logic over pure memorization. If you understand the why, you can solve anything they throw at you. And that's a wrap. Mission debrief for the pituitary is complete. With these logic pathways burned into your circuits, you are ready for what comes next. Consider the Pituitary Command Center secured. You have officially cleared Series E3. But don't get comfortable, because the true 21st century epidemic, the metabolic chaos of insulin, diabetes, and dyslipidemia, that's our next battlefield. If you can't navigate a DKA storm or understand the SGLT2 revolution, your endocrine mastery is incomplete. Your next mission is the Series E4 Diabetes Masterclass. Now move out.